Welcome to this short video to understand everything that you need to know about odontoma. So basically, odontoma is an odontogenic tumor, the most prevalent odontogenic tumor, but the same books that classify the odontoma as an odontogenic tumor will also explain that odontoma is not really a true tumor. Instead, it's an uncontrolled tissue growth, and that's called hamartoma, and basically this is one of the explanations. But what is this? So odontoma is a mixed lesion. Look at your screen now and we are going to understand about this. We have a radiolucent halo and the calcified area started from the center of the lesion, occupying this radiolucent cavity, leaving us with a radiolucent halo, even in continuation with the alveolar crest. And then we have the radiopaque alteration inside this radiolucent halo, okay? And basically that's the characteristic of an odontoma. But then what is this? This is a disruption of the tissue growth of the tooth, preventing the eruption of the impacted tooth. So that's why most of the cases of odontoma are associated with an impacted tooth, associated with the crown of this tooth. So now take a look at this. We have the follicle of this molar here, okay, the impacted molar. And now the radiolucent halo of the odontoma is in continuation with the follicle of this impacted molar, preventing its eruption. All right, but then we have two different types. And look at this one. Which is this one, the type of odontoma? If you want, you can pause the video. It's very simple. This is a radiopaque mass, of course, right? Mass with A. So it's composed by tooth-like tissue, but now in the form of a mass. Why? Because for molars, when we have the disruption of the growth of molars, then it's a big tooth and then it's more likely that this disruption will turn into a mass, a radiopaque mass, with radiopacity that is actually similar to the radiopacities of the dentin and of the enamel, depending on the area of the lesion. So this is the complex odontoma, okay? The complex odontoma is therefore so much more common for posterior teeth, especially the posterior mandible, usually associated with the impacted molars. Look at this. Now, let's see the difference between this one and another case here. So what about this case? Now we have anterior teeth, okay? And then let's see, we have the lesion even blending with the, let me turn on here my Apple Pen, and we have the lesion even blending with the follicle of the impacted tooth. And now we have this alteration here, this alteration here. So we have small alterations which are tooth-like structures. So those are small denticles or toothlets. And this is the calcification characteristic of the odontoma, which is the compound odontoma, okay? Compound odontoma is more common in female patients according to some articles, and the complex odontoma a little bit more common in male patients according to one of the articles. But that's not the most important factor. The most important factor is that since it prevents the eruption of teeth, you can imagine that the patients are young. So the most prevalent age is the second decade of life. This is really important for odontomas, okay? Take notes of this. Very good. Let's see more cases now, and we are going to understand this properly. On an OPG, for example, now it's a little bit challenging because you have all the teeth with the order of eruption, but then you still need to diagnose the issue. So now, where's the issue? And of course, you guys can, I hope you guys are seeing this, that we have the alteration here, right? So look, the radiolucent halo of the alteration, and look, this alteration, so tooth-like structures. And of course, this is a compound odontoma associated with the anterior teeth of the maxilla. Compound odontoma are so much more common on the anterior maxilla, and complex odontoma so much more common in the posterior mandible. This is very important, but now I will of course show to you guys a summary table for you guys to prepare yourselves for your exam. Let's see this now. So we have this case, And even if we need more details, then we can take an intraoral radiograph, a periapical, or even this, an occlusal radiograph. And now take a look at this. We have the central incisor, the impacted central incisor. Okay, let's understand this radiograph. We have the lamina dura of the central incisor here, and of course the apex is open. Okay, that's the apex. The apex is open. We are talking about young teeth. And now, if we follow the lamina dura, then we find the radiolucent halo of the alteration, and then we have the alteration here, small pieces here, of course. Okay, and that's, of course, an image that is suggestive of compound odontoma. Don't forget that we are talking about only radiographic diagnosis. That's not the definitive diagnosis, right? Very good. Let's see now another case. Again, the mandible. So impacted molar. Now we have the mass. And look at this. One of you guys could say, but this is how to differentiate with osseous dysplasia, since we also have the radiolucent halo and the radiopaque alteration inside. Well, look at this. This radiopacity here is very similar to the radiopacity of the teeth. Okay, so look at the radiopacity of the dentin here is similar to this, the enamel. Okay, so not the radiopacity of the trabecular bone. Okay, it's different. But the osseous dysplasia, yes, now you have an alteration that is similar to bone, because now it's the bone that is dysplastic and that is altered inside the cavity. So both are mixed lesions, but they are absolutely different. And don't forget, the odontoma will most likely be associated with the crown of a tooth, not at the apex, the periapical bone area, just like the cemento-osseous dysplasia if it's in continuation with the lamina dura, or just the osseous dysplasia if it's in the alveolar bone, of course. Okay, go back to the videos of osseous dysplasia. There are very nice videos. I will actually add the link on the top right corner of this screen. It will show up at some point. Okay, very good. So now we understood the differences. So let's see the table. And that's the summary table. Take a look at this. Organization. Compound odontoma, highly organized, resembles tooth-like structures. And complex odontoma, not organized. Histologically, this mass would still be similar to tooth-like tissues, but in the form of a mass. They are not organized. Okay, so it's a solid calcified mass. Primary location, anterior maxilla for the compound. So that's how it happens, the disruption of the tooth growth in the form of the compound odontoma, small denticles in the anterior maxilla. But on the mandible, we have big teeth, the molars. And now for posterior mandible, it's usually the complex odontoma, the big mass. All right? That's why radiographic look, denticles or toothlets for the compound odontoma, more common in the anterior teeth, and then complex odontoma, radiopaque mass. All right? Mass with A, of course. Prevalence, more common, the compound odontoma, a little bit more common than the complex odontoma. Okay? So the compound odontoma is more common, and it's a little bit more common for female patients. That's the statistics from research. And of course, when you are going to remove this lesion, then you need to remove this lesion by pieces if it's the compound odontoma. And then if you try to remove the complex odontoma, then it's more common that you are going to try to remove basically the entire piece at once, because now that's a calcified solid mass. All right? Those are the main differences of odontoma, differential diagnosis, and even the treatment. And usually the treatment has a very nice outcome because there's no recurrence, and 70% of these teeth are allowed to erupt properly. Let's see this now. Let's see this case. So we have now this image, of course, which is this one, guys. So pause the video, but I think you guys already know. We have a lot of pieces of calcified tooth-like structures associated to an impacted anterior tooth of the maxilla. Therefore, that's suggestive of a compound odontoma. That's the first hypothesis of your differential diagnosis list. Very good. And now look at this table. 70% of the cases, as I told you, involve an impacted tooth. It's sometimes even more. Now, the most affected teeth the anterior teeth of the maxilla, because the compound odontoma is more common than the complex odontoma. Okay, the complex odontoma can happen also with maxillary molars as well. It's just more common for the mandible. Common complication, failure of eruption, tooth displacement and root resorption only if they develop for a very long time. They are not like a meloblastoma that will resorb adjacent roots very easily and faster, okay? And the surgical outcome, yes, 45 to 75% of the associated teeth will actually eventually erupt. Okay, so it's a very good outcome and there is usually no recurrence. If you guys like, please hit the like button. Don't forget to see all the other cases. We are seeing now the short videos with differences, specific differences of lesions that always get you guys confused. So check those as well and see you soon.